Hello, good afternoon, everyone. Thank you for joining us today. Next slide. So I'll take this opportunity to introduce myself. I am Dr. Miriam Velez Bermudez, and I will be your moderator. I have background in health psychology and public health. I've been working with a clinical kidney disease population since 2016, and I am currently funded under a T32 as a postdoctoral fellow at University of New Mexico under the mentorship of Dr. Larissa Mayakovsky. A common theme of my work is the investigation of psychosocial factors and health equity issues along the kidney care continuum, and I'll continue to build upon that work as I advance in my career, and I'm excited to be here today. Next slide. So today's webinar is Understanding and Identifying Implicit Bias in Kidney Disease Care. Before I introduce today's speaker, I wanted to take a moment to thank our sponsors. We are grateful to the sponsors of our Kidney Health for All program who supported today's webinar. Next slide. This presentation on implicit bias is part of AKF's commitment to raising awareness in the fight for equitable treatment of kidney disease patients. Please visit AKF's Kidney Health for All page to download resources for your patients and support the initiative. Next slide. Today's webinar will have interactive components. I'd like to direct your attention to the control panel you should see on your screens. All participants are on mute, so we will not hear you, but we welcome your questions at any time. If you have a question, please type it into the Q&A feature on Zoom. We will see your questions and we will do our best to answer either by replying to you in the Q&A box or aloud during the last several minutes of the presentation. Next slide. Today, we're also going to be using a polling program called Poll Everywhere. Please take a moment to use the QR code or enter the URL and pin online. We're going to pause here for a moment for you to do this now. This information will also be displayed at the top of your screen during each question. If that seems like it's enough time, we can advance to the next slide. Please reach out to professionaleducation@kidneyfunds.org to request a certificate of attendance. At the end of today's event, you will receive a pop-up request for a brief feedback survey. We appreciate your feedback as we plan additional webinars and resources for healthcare providers. Next slide. Without further ado, allow me to introduce today's speaker, Dr. Anthony Muiru. Dr. Muiru is a nephrologist and assistant professor of medicine at University of California, San Francisco, and I'm going to turn it over to him.
Thank you so much for that introduction, and thank you, AKF, for hosting this webinar, and for everyone joining us from wherever you are. Here are our learning objectives for this hour. And to start with, I mentioned it's going to be interactive section. As you can see, this is instructions on how to join the poll. And the question that I'm asking you all is what word comes into mind when you see this picture? And you all see the words that are coming in. This is anonymous, so feel free to say what words that comes to mind. I see Tennessee Titans, go Titans, athlete, NFL, play football. And I'll give you another minute or so to sort of input what word comes to mind when you see this picture. NFL, it's the main thing I'm seeing. All right, so let's move on to the next question. So same question, but a different picture. So what word comes into your mind when you see this picture? Ty, yearbook. Okay. So education, so university, glasses, work, so give you another 20 seconds or so. Glasses. These are very nice glasses, actually. Right. And so sort of moving on to the next slide, I don't know if the word neurosurgeon or physician came into mind when you saw the first picture. But that picture is actually Dr. Myron Rowe, who was a professional football player. So it makes sense that NFL came up, but now a neurosurgeon in Boston. The second photo, which the words glasses, academic sort of association came up, is actually Michael Swango, who was a physician, but also a convicted serial killer. Why do I show you these pictures? Show you these pictures to illustrate that our brain makes automatic associations that may at times be quite far from the truth. And so in talking about implicit bias, in defining implicit biases, it's important to first define what explicit bias is. So what is explicit bias? Explicit bias are attitudes and assumptions that individuals openly acknowledge as part of their personal belief system. For example, I don't like a person X because of X, Y, and Z. These are things that I openly acknowledge. And because we openly acknowledge these attitudes and assumptions, this can actually be directly measured through self-report measures. And we know overtly racist, sexist, and homophobic attitudes often underpin discriminatory actions. So we compare this to implicit bias. This is attitudes and beliefs about certain characteristics, race, ethnicity. But these operate outside of our conscious awareness. We are not aware that we hold these implicit biases. It cannot be measured through self-reported measures, can only be measured indirectly. For example, through the implicit association test, which we'll talk about this in a subsequent slides. Even though we're not aware of these biases, they influence judgment and can, without intent, contribute to discriminatory behavior. And what's interesting is that a person can hold explicit egalitarian beliefs while at the same time harboring implicit attitudes and stereotypes that contradict what they acknowledge as their beliefs. So how did we develop implicit bias? Well, from being immersed in our society, from being immersed in a society and in our culture. So we are constantly fed information about groups of people. We know that the United States, for example, is characterized as a systemic form of white favoring bias. You may recall the hashtag from a couple of years ago, Oscars are so white, illustrating in this entertainment industry, this white favoring bias in our society. So by we, I mean all of us, you and I, carry in our minds what Dr. Banaji calls the thumbprint of the culture. And I want to emphasize this, all of us. And in fact, little children hold implicit biases because they also consume these cultural associations. So implicit bias is pervasive, it's hidden, and it's very difficult to recognize, especially in oneself. But again, I'm here to tell you that you and I, all of us, we all have some sort of an implicit bias. So why do we care? Why should we care about implicit bias in kidney health and in health in general? We know that there are vast racial and sex disparities in healthcare. And in this particular study, I'll highlight from a number of years ago, assess whether these disparities stem from differences in physicians' treatment decisions. So what do? So the authors developed this computerized survey instrument to assess physicians' recommendation for managing chest pain. So in this study, actors portrayed patients' particular characteristics. As you can see, there are Black patients, white patients, women, men, and they had a scripted interview about their symptoms. So each physician viewed a recorded interview and was given other data about the hypothetical pain. The physician then made recommendation about that patient's care. Now, the concerning findings from this study is that women were less likely to be referred to cardiac catheterization than men. And Black participants were also, as you can see here, less likely to be referred for cardiac catheterization than white participants. The authors also conducted a race-sex interaction analysis that showed that Black women in particular were significantly less likely to be referred for catheterization than white men. And this experiment showed that we are providing differential care based on race and sex of our patients. And if you're thinking, oh, well, this is a kidney disease webinar, while we're talking about cardiovascular disease, while we're talking about chest pain, well, I want to remind you that CVD, cardiovascular disease, is the leading cause of death among our patients with kidney disease. So it's troubling that we, as healthcare providers, are providing differential care purely based on sex and race. So the impact of, one of the impacts of implicit bias. So when implicit bias shows up in healthcare space, contributes to racial disparities in kidney health by influencing communication with our patients and medical decision making. And I'm sure that it's very clear to the audience here that racial disparities in kidney disease in this country are terrible, but it's worth repeating. And the point I want to emphasize is that even though Black Americans have a disproportionate burden of kidney disease, face disparities in optimal care across the spectrum of kidney diseases, from less likely to receive preventive medications such as SGLT2 inhibitors, to less likely to receive home dialysis, and less likely to get kidney transplantation. And my argument is that implicit bias plays a role in these disparities. So let's look at one example that I'll highlight here. And this is a recent study in 2022 that we looked at disparities in SGLT2 inhibitor in prescription in the VA system. And the reason why I think it's important to look at the VA system is because we know that within the VA system, medications are typically covered. But unfortunately, we can see that compared to white VA patients, all issues were statistically significantly less likely to be prescribed these life-saving medications. And this is one way I think that implicit bias shows up in healthcare. We have a system where medication is covered within the system, but yet prescribing medications that we know saves life, that we know slow kidney disease progression by differentially according to race. So how else does implicit bias interfere with kidney care? I already mentioned that it contributes to racial disparities. We saw one example. And another less spoken effect is the negative impact on the healthcare and medical work environment. So implicit bias also limits the diversity of the healthcare workforce, leads to inequitable distribution of research funding, hinders career development, career advancement. And all of these factors further exacerbates disparities in kidney disease. So let me share with you my experience with implicit bias in the workforce. And this is an experience that is unfortunately not unique to me. So I recall when I was in residency, I entered to examine a patient, as I've done many, many times. And as soon as I entered the room, before I even introduced myself, the patient handed me the food tray to presumably take it out of the room. So I gently told her that I was there to listen to her lungs and wouldn't even know what to do with the tray that she was handing me. So she was a little bit distraught by that, and she quickly replied, "Oh, I am not racist. My son-in-law is Black." And the point of sharing this is to demonstrate that even people who don't think of themselves as harboring biases and do not intend to commit microaggressions, they hold these biases. And you can imagine that if this was to happen to me over and over again, I'm not sure that I would be a practicing physician, because it's not ideal to work in a hostile work environment. And another example is when my colleagues hold implicit biases and commit microaggressions against me. So this is a sort of the same time. So I was consulted to see a patient and discuss the case as we typically do on the phone with the primary physician, and gave my initial recommendations, and then went to see the patient. And as I was entering the room, I recognized the name of the primary physician from their badge, who quickly asked me, "Oh, where is the patient going? Where are you taking the patient?" Because they assumed that I was there to transport that patient, not to offer a consultation. Again, I share this to illustrate how implicit bias shows up in the work environment. And if this was my sort of day-to-day experience, you can imagine that at some point, I may get fed up and sort of decide to do something else. So implicit bias has impact on clinical care delivery, on disparities, but also on making a work environment particularly hostile. And that can lead to forcing certain individuals from their workforce. And lastly, so when I reflect on these episodes, I remember my Black patient who once told me that who once said, as soon as you remove that white coat, they see you the same way they see me. And I remember thinking, and actually replying to him, I was like, "No, sir, even with the white coat, they see us similarly." And I put this here to emphasize that biases are pervasive and happen across all sectors of society, whether it's from criminal justice, as illustrated by this Netflix series, to healthcare. And so it's important to really be aware that implicit bias is quite pervasive. So let's talk about how implicit bias show up in kidney disease research and clinical care. And for this, I have another poll for you all. It's a true or false question, asking African Americans typically have higher muscle mass compared to other races. I'll give you a few seconds to answer this question. I don't know how many people have responded. I can't see the actual number of responses, but I'm seeing 100% of folks reporting that it's a false assertion that African Americans typically have higher muscle mass compared to other races. And so that is true, which it is true, it's a false assertion. I bring that up to remind everyone of the race coefficient in AGFR. And I'm so glad that we're talking this in the past tense and no longer deal with this today. But just to remind you that it was introduced the race coefficient was introduced in 1999 and remained in clinical practice until 2021. So it's a long time. And the original reason that was given for this was to believe that Black individuals have greater muscle mass. And I think it is this false belief that partly explains why we held on to this race coefficient, race-based GFR reporting for so long. You know, society had already impressed upon us that Black people are different. And so when a prominent article is published, we did not look very hard to question certain assumptions. But I'm glad that we no longer have to deal with this at this point in time. So another question here. Several studies have definitively demonstrated inherent differences in measured kidney function between Black and white patients. I'll give you a second to respond. Again, I'm so happy that depending on the number of responses that we've had, maybe this is a leading question, but I'm glad the overwhelming, really everyone is saying that this is a false assertion, that there are no studies that have demonstrated there are differences in measured kidney function between Black and white patients. And, you know, we're all aware of this. So race is a social construct. There are no inherent differences in measured kidney function between Black and white patients. But remember, we held on to that coefficient from 1999 to 2021. The differences in kidney function measurement observed in several studies that have been reported never be generalized to the general population. And again, even though this was not directly actually measured, I believe that implicit attitudes and beliefs about Black individuals contributed to the persistence of the race coefficient in clinical research and clinical care. But I'm glad that now we've sort of evolved and no longer carrying on these practices. All right, another poll question for you here. So kidneys from African American / Black deceased donors are suitable for transplant than other deceased donors. Give you another 10 seconds. Okay. All right, and this luckily everyone agrees that that's not a true statement. However, the KPI, I'm just going to a few moments to talk about the KPI. So again, illustrate how when we introduce race into clinical algorithm, it can perpetuate inequities in care. So as formulated previously, the KDPI would assign a kidney from a Black donor would have been deemed less desirable purely based on race. And again, I think the persistence of this algorithm is in part due to the false beliefs that we have about certain individuals. But it's important to really consider the implications of our policies. And for me, this is an issue that I particularly care about. It's important to me professionally as a nephrologist, but also personally. So this is actually a picture from 2 years ago when my mom became a deceased donor. And this is actually, this picture is from the bedside around that time. So the idea that her kidneys were less desirable because of her race is quite disturbing. But happy because due to advocacy from various groups, including AKF, as shown in this letter, the KPI no longer includes race, as you can see it with this announcement. So I'm very happy that we are moving forward. So let's now return to talking about implicit bias. And here's another question. True or false? Physicians and nurses, so healthcare providers, manifest implicit biases to a lesser degree than the general population. Is that a true or false? A few seconds to answer this question. Once again, this is a stellar audience, but it is a false assertion. We know from several reviews I have conducted, have asked this question, physicians and nurses, and really the healthcare force, manifest implicit biases to a similar degree as a general population. This makes sense, right? So remember we said that the reason why I have implicit bias is because we carry in our minds the thumbprint of our culture. And so it makes sense that we share cultural influences with the general population. So physicians, nurses manifest implicit biases to a similar degree. The problem is when this implicit biases enter the healthcare space, there's a negative correlation between the level of implicit bias and indicators of quality of care. So we're not providing adequate care because the implicit biases that we are bringing in from our cultural influences to the healthcare workforce. All right, one more question. Some implicit associations are justified because they're based on prevalence data for diseases. A true or false question? So yeah, false. Implicit association cannot be justified because they're based on prevalence data for diseases. And so, in fact, when we justify our implicit biases, we provide inappropriate care. There's one study that found that many diseases that were associated with African Americans did not match prevalence data, right? So if you're bringing in assumptions that because this individual is from a particular group, so therefore the condition in which they're presenting with is likely to be X based on prevalence data, that's gonna lead you to providing inappropriate initial and follow-up care. So applying a group level stereotype to an individual can lead to inappropriate care. And let's see how that works in an actual case. So this is a case of a 45-year-old self-identified Black transgender woman with a history of well-controlled HIV who presented elevated creatinine and nephrotic rich proteinuria. And I'm not giving you a lot of details, but the question I'm asking you are, in the assessment of this patient, should I get a kidney biopsy to evaluate the cause of kidney dysfunction? The options are no. The most likely diagnosis is FSGS/Hyven, and the kidney biopsy is not needed because it will not change management, so that's been cut off there. Yes, I should get the biopsy because the etiology of elevated creatinine and proteinuria is not clear. And then lastly, I don't know. Give you another few seconds. Think about this and enter your answer. And remember, you can, this is anonymous. You can answer however you feel. And I can see that I'm glad now we have a little bit of variance in the answers. And majority of people, or half and half, 40%, 40% said they will get a biopsy. The other 40% say they did not, and the 20% said they would not because the etiology is clear. So this was actually a real case. And I have to confess, initially, I was committing a implicit, I brought into the space implicit bias and committed a microaggression this patient, sort of saying that I think this is just FSGS in Hyden. But it turned out not to be. I was a trainee at the time, and luckily my supervising doctor guided me towards the right decision making, and we ended up doing a biopsy that was there was definitely not FSGS and definitely not Hyden. And more importantly, it changed the way that we treated this particular patient. So again, to illustrate that applying sort of group level stereotype to an individual patient can lead to inappropriate care. So I hope I have convinced you that implicit bias is everywhere. I hope that I've shown you what happens when we bring implicit bias into the clinical workspace. So let's now talk about strategies to combat the harms caused by implicit bias. And the first question I have for you is, which one of these strategies have been shown to reduce implicit bias? Have been shown in experimental design or in studies reduce implicit bias. So exposure to counter stereotypical exemplars, recognizing and understanding others' perspectives, appeals to egalitarian values, or none of the above. So a few more seconds for you all to think about this. Like this, I'm seeing a little bit of variance in the distribution. Exposure to counter stereotypical exemplars, about 17%, 67%. So recognizing and understanding others' perspective, and 17%, none of the above. And the surprising sort of findings is that actually is none of the above. So no intervention for reducing implicit biases have been shown to have enduring effects. Now that we know that there are many companies and many sort of folks who would conduct debiasing sessions to try and root out implicit bias. And those strategies are interesting, but when we look at the evidence, there have not been any intervention that have shown that after participating in a particular workshop, that implicit biases have been reduced. So what should we do with that information? What we should do is to, instead of trying to root out implicit bias, which I'm arguing we cannot, again, implicit bias comes from the cultural influences, the thumbprint of the culture is what's happening all around us. We should instead focus on eliminating discriminatory behavior and other harms caused by implicit bias. In other words, we should acknowledge the implicit bias is here, be aware of it, and then address the consequences of implicit bias. So how do we combat the harms caused by implicit bias? Well, awareness of bias is the first step really, I would say, toward behavioral change. So how can you be aware of something that you don't even know that you have. Remember, in the beginning, we said that implicit bias cannot be easily measured. Oh, and no, it cannot be easily measured. There are tools that are freely available for everyone to be aware of their biases. And in this, I'm saying sort of check your biases at the door. And the most sort of famous way to check your biases is the Harvard Implicit Awareness Test. If you've never done one, I encourage you all to definitely do it. You know, it's anonymous and it gives you important information about the biases that you hold. So I encourage everyone to, who, if you've never done it, just sort of voluntarily just go to the website, and I'll show you their website in a little bit, so that you can be aware of which particular biases that you hold. I confess that when I first took it, I was surprised by the biases that I myself hold. Quite surprised by the finding of my own IAT. The other approach is to, again, just accept that it's pervasive. So I expect that you possess an implicit bias because it's everywhere. We all have it. The other approach is to use knowledge of your explicit attitude or stereotype as the basis for guessing what implicit attitudes that you may have. Why do we say this? Because we know that explicit attitudes and implicit attitudes are highly correlated. And I was mentioning one tool that we can use here is the implicit association test, which measures attitudes and beliefs that people may be unwilling or unable to report. This is a very important tool for individuals to discover their implicit biases. And as I mentioned, I welcome everyone to use at least one or two IATs. This is a QR code, the website, you can see it on the bottom here. And there are some more information about what the tool is measuring and tells you what to do with that information. I encourage everyone to join. Next strategy that I will mention is once we are aware of implicit biases, is education on implicit biases. For example, we're having this workshop that is talking about implicit bias. But I think that this education should be standardized at the health system or institutional level. There's one example here that I have, which is online modules, which actually has been shown to increase providers' biases awareness, and I'm citing on the bottom. And another approach that's taken in other countries, not currently in the US, is accreditation bias should require instruction on implicit bias, because as we saw, this is pervasive and it cuts across our work environment, our clinical care. So it's an important aspect to bring into folks' awareness. The last thing I'll mention is this tool called bias reporting mechanism. And I'll highlight one system out of the University of Washington. There, you may have this at your institution. Also, UCSF has one. And any other system have this. And so basically what it is an online tool for reporting bias incidents by target or observers. If you see a bias incident happen or happens to you, you can report it. And this is evaluated by incident response team. The information is gathered and the concerns are directed to the appropriate system. The other important part of collecting this type of data is that they're able to generate reports about how many number of biases are we seeing, what are the affected groups, and what are the themes. And this can give the institution sort of valuable information into, again, trying to mitigate the effect of various biases. I think of this as, many healthcare system has mechanism to report, for example, falls or catheter-related infections. And they use that to, they collect that type of data so that they can use that information to improve systems. So I think this is one strategy that institution can use to mitigate the impact of bias. So in summary, I've mentioned that we talked about that implicit bias is pervasive, is hidden, and is difficult to recognize, especially in itself. But when present in research, clinical encounters, medical education, implicit bias can worsen health disparities. We've talked about 3 strategies to mitigate the harm caused by implicit bias, including awareness. I think that's the first step for all of us. It's important for you to be aware of whatever biases that you have. And I can assure you that you hold and I hold a biases toward certain characteristics. Education about implicit bias is important, especially standardized education. And then lastly, reporting, so bias reporting, so that institutions and healthcare systems can quickly address and mitigate the harm caused by these biases. And to end, I'd like to leave you with this quote here from one of my favorite podcasts called The Hidden Brain, that actually dives in quite deep about implicit bias. And Shankar in this episode says that individuals can do their part to limit the effects of behavior. But if you want to fix the bias itself, that takes a whole village. So it's going to take all of us, it's going to take a culture, it's going to take everything and everyone to really reduce the impact of bias itself. None of this will happen unless we start with the individual, and individuals can do their part to limit the effects of biases. And that concludes my remarks, and I will transition to questions.
Thank you so much, Dr. Muiru, for that thorough review on this topic. It was a great presentation. I'm seeing if anyone has posted questions in the Q&A at this moment. If not, I can start us off. I really loved that quote that you had at the end there, Dr. Muiru. And I think it's so important for all of us, for healthcare providers to do the work to address their own implicit biases, since implicit biases can have such disastrous effects on patients. But in addition to that, patients tend to experience implicit biases, not just from the healthcare provider, but from anyone when they're walking in a clinic, from a security guard or an admin person. So by the time they see the healthcare provider, they may have already been hit with a lot of microaggressions at that point. So as healthcare providers, what can we do to identify what systemic biases are happening in our own practice and organization? And then how can we leverage our positions to address them?
That's a great question, and 100% correct that, you know, by the time the patient is seeing us, they've already sort of walked through several layers, and each of those layers is an opportunity, unfortunately, for a microaggression to happen. So how do we mitigate that? Well, I think one approach is definitely to make sure that everyone who is part of that system, from, like you mentioned, from the security guard to the physician, everyone is aware of their own implicit biases. So bringing awareness to the forefront, and then on top of that, collecting data on what are our patients saying, right? So collecting, specifically asking our patients, what has been your experience from the time you called to make an appointment to the time you came to see us, and then using that data to screen out incidences of microaggressions and really addressing them. So I think it's going to require a whole system where we are collecting information about uh, when are these incidents, when are these incidences happening, by whom, at what section, and obviously addressing those incidences that they happen. So I think the key point is collecting data so that we know that these incidents are happening and this is what we're going to do, and at what level, and addressing them as they happen. And you're right, but you're right. It's going to happen across the spectrum from the time you make the phone call to make an appointment to the time you see a physician. So we cannot sit back as physicians and say, we're going to be trained in implicit biases and forget that before our patients get to us, they went through a maze of different levels. So thank you for bringing that up.
That was a wonderful response. Thank you. It looks like we have a question in the chat, so I'll start there. So what can patients do to address implicit biases?
Yes, very good question. Again, so we have to center our patients, right? So as a patient, so there's levels to this. As a patient, unfortunately, I know that patients will suffer microaggressions. We will commit microaggressions against our patients. And we cannot leave it up only to them to report this if this happened. Because if you imagine when a patient has chest pain, they're there to worry about the chest pain, and they may not even have the capacity to tell us that X, Y, and Z happened. So I think that we have to create systems around the patient so that we are observing and documenting when things are happening, right? The other aspect is, of course, we have to empower our patients to, and I know they have a lot to deal with, but create a system in which they can report when these incidents happen. Remember, we are customer care people, right? So if you go to Best Buys or a store and something happened, as a client, you would sort of report, speak to the manager, you would do something to report an incident that happening. So I think we have to empower our patients to report and let us know when things are not going well. But again, we cannot just only put that on the patients because patients have so much to deal with. We have to create systems to detect and look out for these incidences when they happen.
Thank you. I love that point about holding systems accountable instead of just putting the onus on the patient. This question came up during your review of the literature. So regarding differences in kidney disease by race, can any of these differences be attributed to social determinants of health?
Yes, absolutely. Yeah. So we know that when we do differences in a particular outcome, a particular measurement, and we do see differences, the punchline is that it's important to not attribute that to a particular characteristic of a particular group. It's possible that we are measuring or detecting the impact of social determinants of health, the impact of structural racism, the impact of geographical distribution, but we are not, when we see differences, it's unlikely because we know that race is not a biological factor. Right? So the differences that we may see are likely coming from social determinants, structural racism, all those things. And if us to equate them, say all Black people, all X group of people have this, because that's not really accurate.
Thank you. So I just want to give a reminder, we may have time for one or two more questions. Please put your questions in the Q&A. I'll throw out a question there. Is there a business case that healthcare providers can make to their administrators to include implicit bias training and assessment?
Absolutely. We mentioned that implicit bias contributes to racial disparities. What I did not talk about is how much does this racial disparities cost in our healthcare. So we're not only not providing equitable care, but it's expensive. And so the business argument for this, beyond sort of like the sort of moral argument where we should provide equitable care, expensive to provide inequitable care. So it's a no-brainer to me that healthcare systems should do everything they can to reduce health disparities. Yes, for the moral reasons, but also because health disparities are expensive. And so, yes, there's a business case for health systems to uh, to do whatever they can to reduce health disparities, and part of that is addressing the impact of implicit bias.
Thank you so much for answering those questions, Dr. Muiru. I doesn't seem like anyone else has added anything to the chat or the Q&A. So I guess we can move forward.
Yes.
Unless you have anything you want to add. You have great perspective.
Yeah, no, I would just, yeah, no additional comments on my end. I'm gonna proceed to the next slide.
Okay, so some housekeeping. For more information on AKF professional resources, please visit kidneyfund.org/professionals and research. If there are any topics you are interested in to support your patient care, please share it with us at professionaleducation@kidneyfund.org. Next slide. Thank you again, Dr. Muiru, for joining us today to discuss implicit bias. It's such an important topic, and you did such a good job giving us a in-depth overview of the topic. And thanks again to all the Kidney Health for All sponsors for sponsoring today's webinar. Next slide. So please check AKF's YouTube channel to view the on-demand recording of this webinar. Thank you again for joining us, and we hope to see you again soon.